Your heart health is so important. UofL Health's Dr. Amir Piracha knows that firsthand since cardiovascular medicine is his specialty. Welcome to Great Day Live. Dr. Piracha, what conditions do you treat that patients should not wait for?
Well, first of all, I want to thank you, Angela Renee, for having me on.
My mom will love that.
um, so what was the question again? I'm sorry.
What conditions do you treat that? I mean, because you know this, way back in March, people were not going to get
Right.
treated by doctors for anything. But what conditions do you treat that they just shouldn't wait for?
Well, we were running to this trouble. Everybody was scared. And unfortunately, we had a few people, in my own experience, being on call that waited 3-4 days while they're having an active heart attack because they were scared to go to the hospital. And of course, that makes it very difficult, not only if you're going to balloon it or stent it, but because by that time the heart muscle may have already become a scar tissue and it's hard to get that function back. So the patients, I would say, if you're having any symptoms, cardiac or non-cardiac, where you're shorter breath and it doesn't improve with your normal, say you're an asthmatic and you're using your inhaler, it's not getting better, or you have emphysema and you're using your oxygen, you're not getting better. Or if you start feeling chest pressure, breaking into sweats, getting dizzy, lightheaded from that, these are all conditions where you don't want to wait. You'd rather go to the emergency room and get checked out. There is a risk, of course, especially in March. It was almost like that original AIDS epidemic when it came out. No one knew where it was coming from. They were scared to touch doorknobs and they didn't know what was going on. So everybody was just paranoid, which we needed to be paranoid. We needed to take care of ourselves and wear our masks and wash our hands. But at the same time, by staying home, you could end up making everything worse instead of going to the emergency department for those conditions I just mentioned earlier.
I mean, especially when you say someone is having an active heart attack and they wait that long, that just shows you the fear.
Right. And there were a lot of patients we had who had known heart disease and they knew what their symptoms were. And that was even more frustrating because they would have their typical chest pressure and they would try to hide it from their family member or whatever until their family would finally see it and say, hey, what's going on here? And they would tell them and then they would end up in the ER. So that waiting was really tough because me and a lot of my partners, we saw this where patients knew what was going on. They knew what was happening, but they were just so scared to go in because they're afraid they would come out with something worse than what they went in with.
So, how are you ensuring a safe environment for your patients now?
So it's like a big curve. At first, when it all started, we were not allowing basically anyone into the hospital. I had a patient of mine who came in. We were trying to push him to not have heart surgery, but the poor guy kept coming in multiple times with heart failure. And eventually he just got admitted and we had to do the heart surgery. So that gentleman, I saw him yesterday. He's doing great, but that poor guy had no family that was able to see him in the hospital. He was alone here for a whole week. He had open heart surgery. He was in a room by himself and he was discharged. But we did that for his safety and for his family's safety and for the staff's safety. He was able to obviously FaceTime his wife every day and do all those things, but it's not the same, obviously, than having your loved one there with you. So we told everyone, you're not allowed to come in. I had friends of mine who even, if their child was 18 years old, if they're a minor, it's a different story. But if they're 18 and above, they would take them to the ER, they would go in, and they would have to wait out in their car until their family member was ready, and they would, send them home.
But obviously, things have changed, and I mean, safety is at the utmost.
Right.
And we know more, even though it's a fluid situation, it feels like, but we do know far more than we did back in March.
We do. We know more. We know that, by using the proper precautions, we can decrease the percentage-wise. I'm not going to be Dr. Fauci and give you a bunch of numbers, but what I would say is that we know that if you keep your distance, you wear your mask, you wash your hands, all these good things, you will protect you and your, friends and family around you. What we are allowing now in the hospital, what we do, for example, today is my typical heart procedure day. We're having people test for COVID on Monday because it takes 2 to 3 days to get the results back. We ask them to kind of self-quarantine themselves while they're waiting for that test to come back, so nothing happens in the last 24, 48 hours. And they're allowed to come to the hospital, and we have a separate bay for them and one family member. So their family member comes with a mask as well. They sit in that bay. They wait for the person getting the procedure. They go to get the procedure. They come back to the same spot. So there's not a lot of transfer. So you start at point A, you go to point B, you come back to point A, and then you go home. And versus, before it would kind of be like this circular thing, and there's a risk of touching multiple different spots, and then you have to over clean multiple times. So now we're doing there. Also in the waiting room, we allow very few people. Usually we have the chairs set up with one chair facing this way and then 2 or 3 chairs facing this way and then another. So there's no opportunity for people to get too close. So we're doing all these things just to remind people about their distancing. But it used to be it was a free-for-all in the waiting room. You walk out and every family member is sitting out there waiting for 10, 12 different doctors doing procedures. But now it's basically a ghost town when you walk in the waiting room. They just have the family member sitting in what we call the bay, which is like the pre-op area. It's a separate room. So I think it's probably something that should have been done a long time ago anyway. Now we're just learning better habits. And, our own parents and grandparents used to tell us to wash our hands after doing everything. Mm-hmm. And now, we realize it's probably a smart idea to wash your hands.
Definitely. Now, what about changes, Dr. Piracha, that you've made to your practice or the delivery of care in concern with COVID-19?
So early on, so for the first 2 months, I was kind of joking with my partners because my partner and I, we kind of made this policy that everybody would stay in their own little silo. So I would stay at Dutchman's Lane at Jewish East, and that was my practice every single day. I was not allowed in the hospital. I used to joke because I'm over 50, and I said my junior partners would tell me I'm old, I'm high risk, so they keep me out of Jewish East and the high-end population where there's, not downtown with all the sick patients. So, but seriously, I used to go there every day. We'd come in, get our temperature tested, wear our mask, and most of my patients, we were trying to avoid any contacts in the office with our routine patients. So we have patients who see us like once a year. Say I put a stent in them 12 years ago, and they come in and check in once a year, make sure their cholesterol is good, blood pressure is good. But those patients, we moved them back. So a lot of these patients, instead of 12 months, I saw them now in the last month after Memorial Day. So it's like 15, 16 months. But we also were very good about making sure all their prescriptions were sent in. So there's a policy. It's kind of unofficial rule that most practices run, that if you don't see a patient within a year, you don't want to refill their medications because you don't know if their health has changed, if they need to be on different medicines. But everyone agreed that we would refill everyone's medicines even if they didn't see us, so they wouldn't run into trouble. If they have heart failure and they miss a couple of days of drugs, they can end up in the ER and make the situation worse. So that's what we did as a practice, our cardiology practice. We had everyone siloed into one spot. So I was in one spot with one medical assistant, one front desk person. And that way, if God forbid someone got sick, we knew to shut down one clinic instead of shutting down the whole hospital system. Absolutely. So we didn't cross-contaminate with our other partners.
Definitely. Now, Dr. Piracha, what about health disparities? What do you see within your practice that you think maybe the general public should be aware of?
Well, we know for a fact, right, that there is a health disparity. People of color and also different financial situations, they are at higher risk. And it may be just because more people live under one roof. Or somebody has to physically leave their house to go get their job. They can't work from home on a computer, et cetera. So this is a problem. We saw different parts of Louisville where you saw it hit higher than other parts of Louisville, whether it's their financial situation, whether, their race. So I think it is a very important aspect. And for example, my parents, they now live in Northern Virginia. My dad's a retired physician, and he had no problem staying at home. He had the home, he had a little basement with a couple dumbbells, a stationary bike. He could work out every day. He's 81 years old. My mom did the same kind of stuff. And my sister lived close by. She could drop off groceries, and they could keep that social distancing. But what would happen if they weren't as fortunate and they had, 4 grandkids and a daughter and maybe a son-in-law living under their roof, and everybody has to still go out and work somewhere to make a living, it'd be harder to protect them. So that is the difference in the discrepancy on what we saw, around the country.
Definitely. Last question for you. Why did you decide to practice medicine?
Well, it's a very long story, but I'll try to keep it short. So my dad was a physician in a small town in West Virginia. He was the only physician out of his whole family. Everybody else was in business on both sides of my family, my mom's and my dad's. And I just saw, like, when you're in a small town, it seems like as a physician, you can always make a difference. And then I was fortunate enough to live in Pakistan. I was born and raised here, but I was fortunate to live in Pakistan with my grandmother for a year when I was 12. And I saw there that, medicine has no borders, just like doctors have borders. I mean, you can go anywhere and make a difference. But if you're a lawyer in the US, there's different laws in different countries. If you're a businessman, you have different language. But, medicine, you can help anyone, anywhere. So that's kind of what started it. And then as time went on, it just kind of grew. And I kept on going back to that. And probably I wasn't talented enough to do something else, If I was a real genius, like if I was a Steve Jobs or one of these guys, I would have come up with some great creation, and that's been different. So medicine is one of those things. As long as you don't mind the grind, just grind it out, you can usually make it with an average intelligence.
I think most of us are going to go ahead and disagree with you there and say that fixing people's hearts, pretty big deal. Dr. Piracha, thank you so much for taking the time.
All right. Thank you so much. Take care.
To learn more about UofL Health and find a physician or specialist, visit uoflhealth.org.